Welcome to unRemarkable Labs. You probably know that I'm Bob Centaur, and probably the founder of unRemarkable Labs, but they're really run now by our great queen of unRemarkable Labs, Natasha. So Natasha, why don't you introduce yourself?
Hey guys, my name is Natasha Mera. I'm a second year at UAB for internal medicine residency, interested in general medicine.
Gabriella, go ahead.
Yeah, hi everyone. I am Gabriella. I'm also a second year resident in internal medicine at UAB. I'm interested in cardiology.
And something that's very important here, all three of the other people here have worked on my team at some time during their career.
And point out that I was there as a third-year medical student with you at the VA.
Right, and he still went into medicine. Todd, go ahead and introduce yourself. Todd is really the reason for this particular unRemarkable Labs, although it looks like I'm going to be doing some work too.
My name is Todd McCarty. I'm an infectious diseases physician at the University of Alabama at Birmingham as well. I will call myself a PGY. I think I'm up to 12 now. And I am also our fellowship program director. So lots of education during my days.
And you're really, would you say you're a fungal expert?
I try to be. I'm no Peter G. Pappas. But people do like to ask me fungal questions, so I guess
you do see a lot of fungal patients.
Yeah.
Yeah. So you have more experience than the three of us combined. So Natasha, tell us this short story, and then Todd and I'll sort of bounce around the labs.
Yeah, sounds great. So we have a young female in her late 30s presenting with cough and shortness of breath that she says has been going on for 2 or 3 weeks. I can give a little bit more history. Sorry, 56-year-old coming in for shortness of breath, cough, and hypoxia. And she says about 2 weeks prior to admission is when she initially developed some symptoms, which were headache, body aches, and this interesting kind of rash with just light brown raised papules on her skin, which she hasn't really thought much of. But she's coming into the ED today because she's having more and more trouble breathing. And the ED calls you for this admission. She is afebrile, barely at 37.4, a little bit hypertensive with a pressure of 153/94, tachycardic to 112, and satting 94% on 4 liters of nasal cannula. And Dr. Centaur, I will just let you go right at the labs because I'm sure you were very excited.
Well, I'm going to spend most of my time on the electrolyte panel. I'll say a few things about the CBC, and then see, since Todd is an ID expert, see how he looks at the CBC. The first thing I noticed is that her sodium is 117. That probably just means she's really sick, because when you're really sick under have a lot of stress, that produces ADH. So you could make the case that that's part of it. Now, you could also make the case that she might well be volume contracted also, given her bioendocreatinine ratio. You could also make the case that we need to worry about, make sure she doesn't have adrenal insufficiency. And the reason for that is she has both hyponatremia and hyperkalemia. And that's sort of unusual that she would have hyperkalemia in this situation. Now, we don't know her past medical history, what medication she's on, etc. But anytime I see a low sodium in someone who's really sick, I want to make sure I don't miss Addison's. Now, it's probably not that because her blood pressure is really quite good, but still something to think about. Her bicarb is 17. It's a normal anion gap of 9. So she still could have a lactic acidosis. So this is a really important pearl that I learned several years ago. You get lactic acidosis before you get the increased anion gap. There's a whole series of studies in the emergency medicine literature. And so it is worthwhile to check a lactate. But given her complaints of hypoxemia, her cough, her shortness of breath, my guess is that she's had chronic respiratory alkalosis from hyperventilation, and that perhaps her bicarb is low because of that. It'd be really unusual to come up with a reason for her to have a normal gap acidosis. So I would get, hopefully they got an ABG, and I think an ABG is really helpful to see how bad her AA gradient would be. But that also will see whether or not we can explain that bicarb as secondary to the hyperventilation. If that's true, you don't want to give her bicarb. You want to improve her oxygenation, and then her kidneys will take care of everything. I guess she has diabetes. I'd like to know how long she's had diabetes. That 36-14, either she had a GI bleed or she's volume contracted, I would guess. My guess is that in situations like this, people underestimate their insensible losses because they're breathing so hard. And so volume contraction is really quite likely. So there's a lot there. Now, given that her hemoglobin is probably even lower than we see. So after we give her fluids, I wouldn't be surprised if she has significantly more anemia. The low platelets are concerning because usually your platelets go up when you're under a lot of stress. It's sort of an inflammatory marker. So I don't know what to do with that. Her white count is slightly elevated. We would love to see a differential. We think she has some kind of infection anyway. And I will just assert, this is not community-acquired pneumonia. She's been sick too long for this to be community-acquired pneumonia. I don't care what her chest x-ray shows. It's not, she might have some kind of pneumonia, but she doesn't have community-acquired pneumonia. So Todd, now that I've blabbered on for a period of time, do you like what I had to say? Do you want to add to it and perhaps correct anything that I said?
Yeah, no, definitely. I don't have anything to correct, and I think I will highlight the important ones that I would take. You know, one, you commented on the duration of her illness. This isn't pneumococcus. This isn't your typical community-acquired pneumonia. So she's already starting off in an unusual bucket, and then you add a rash on top of it. And so there's seems to be something going on extrapulmonary, whether that's an immunologic process or a metastatic infectious process. Those are things to think about. Looking at her labs, I mean, her BMP is strikingly abnormal. How abnormal, I think, requires knowing a little bit more about what her baseline condition looks like. And I think you hit it on the important parts of the CBC. Her white count's elevated, but not profoundly so, and may even actually be under the cutoff of the upper limit of normal. And her platelets are low. And so we need a little bit more context. Who is she as a patient? What are her medical conditions? What does her baseline labs look like to really place this into context?
What are there any particular infections that that you're going to, as we get more information? So the way clinical reasoning usually works for experienced physicians is that when you heard the raised papules and the cough and hypoxia and saw these labs, they're and you know it's not a regular community-acquired pneumonia. There's certain things that would fit the illness script thus far, which we know is going to change, and that sort of directs the questions you ask as well as how you listen to the answers. So what are you thinking at this point, Todd?
So I think I still want to know more about her as a patient before thinking about a possible differential. You know, you see the low platelets. Is this chronic? Does she have cirrhosis? You know, when we know that increases her risk for things like cryptococcus. You know, we know that histo likes to come with a lot of skin findings as well. They tend to be more ulcerative. Blastomycosis can also come with skin findings. Those tend to be deeper subdermal nodules and abscesses. I guess sort of focusing on the fungal world, since, you know, that's what got brought up. Those would be the key ones that I would think about given the somewhat prolonged course. But how much I think about them will really depend on who she is as a patient.
we don't-
Other kind of odd and unusual infections that can pop up in the right host. Certainly nocardia, we think of lung and skin. Aspergillus, we can think of lung and skin. TB, but usually these other things are more common in low endemic areas like the United States.
If she'd been to Arizona, would coccidio be in our differential?
Certainly, I don't. I will confess that I don't fully know all of the extrapulmonary ramifications of cocci because we almost never see it. But we actually have had a couple in the past year that have had travel out west and have come back and had things like meningitis and other complications.
And the other thing, we don't know what time of year it is yet, which could be important. Would any of the tick-borne illnesses look like this? Or would some of the rickettsial illnesses? I know they get rashes. I don't remember light brown raised papules.
Yeah, I think that would be unusual, and I think one other point that I think is being increasingly talked about is understanding what her rash is in the context of what her natural skin tone is, and being sure that that's part of our understanding of illnesses. Is what does a varying rash look like? We know what the common petechial rashes with tick-borne illnesses look like on primarily white patients. It's a little bit harder to see them in African Americans and other races with darker skin tones. And so I think it's an important part of improving all of our education.
Great.
So I will give you guys a little bit more information. She said that 1 week prior to admission, that's when she started developing a non-productive cough, shortness of breath, fevers, chills, and night sweats, at which point she decided to go get tested for COVID. She went to an urgent care. They also happened to test her for flu and strep pneumo, which were all negative. And so that's when she came into our ED. She didn't have any chest pain, joint pain. We've already kind of talked about her other positive review of systems. A little bit about her as a person. So she has ESRD secondary to FSGS and did have a living donor renal transplant in July of last year. Overall is doing well from that. She's on myclophenolate, prednisone, and tacro, kind of the standard regimen. And she also has some hypothyroidism, for which she takes levothyroxine, and hyperlipidemia and hypertension as well. Her other medications, she's on Bactrim prophylaxis 3 times a week. Family history, really only remarkable for her mother having had a stroke in the past, and her surgery, we already talked about her renal transplant. In terms of her social history, she lives in Wetumpka, Alabama with her husband, doesn't drink any alcohol, use tobacco products, e-cigarettes, or any recreational drugs. What are you thinking now?
Go ahead, Todd.
She is the right patient for all the potential unusual things. And so crypto certainly rises up very high. Histo rises up very high. I would say both of those in terms of the potential for fungal infections are probably going to be more likely than any sort of invasive mold disease, but those are all still possible. Not just aspergillus, but we think of the pigmented molds, also called dematiaceous molds, whose characteristic is melanin production for their cell walls. She's, an immunocompromised host. She's got a prolonged course. You would want to ask about specific exposures. You mentioned Wetumpka. When we think about, histo in Alabama, we think of primarily the Montgomery area, but really it can occur anywhere in the northern, about 2/3 of the state. I think usually it's in areas closer to the water, even though if you think about board exams, they're always telling you about people going through caves and being around bats and birds and pigeons and things. Most people, we see that, of course, but most people, they don't give us any particular exposure that I think of for any of those things. Nocardia may be less likely because it seems more like a kind of disseminated rash, although we'll get into the exam, and that tends to cause more of abscesses and ulcerations. Other kind of odd and unusual things, she's hypoxic, so we have to think of pneumocystis. I don't know that I've personally ever seen a skin rash that I would blame on pneumocystis. Those are sort of my biggest concerns at the moment. And I'm very quickly going to want a lot of imaging and, depending on what we find, a piece of tissue and maybe some other ancillary tests, but I guess we'll get into that.
I just wanted to throw in, and this is not diagnosing what she's here with, but tacrolimus can cause a type 4 RTA. So it's possible that we can explain her high potassium and low bicarb from that. So I'm hoping we have a blood gas. We can see whether or not she has, does she have primary metabolic acidosis, primary respiratory alkalosis, or both? I know that both Gabriella and Natasha have heard me say this a million times, but are these chills, are these shaking chills, are these rigors? And if so, are they recurrent? Are these drenching night sweats or just a little bit sweaty? Because I never know what you mean when you say night sweats until you give me a little bit more. And how often they occur might help us. So for example, someone who has one drenching night sweat and one rigor and then comes in with cough and short of breath, that's probably pneumococcal pneumonia. Someone who has recurrent, now we're thinking about TB and fungal infections much more, or we could be thinking about lymphomas or something like that.
I think that's a good point. Again, I have this sort of anchoring bias to talking about fungi, but common things being common, this could just as easily be endocarditis, and we're seeing septic embolic events related to that, especially if she is having night sweats, rigors. Could this be, just Staph aureus? I mean, you see a whole bunch of Staph aureus in the blood, and does she have been unfortunate and has endocarditis now, or enterococcus, or any of these other number of things that we can see quite frequently, especially in, she's chronically ill. She was on dialysis. She's a transplant patient now. She's going to be at risk for all sorts of complications.
So the rigors, and she has been having chills and rigors and drenching night sweats, and these primarily started about a week ago and have kind of progressively worsened.
So Todd, do you see that a lot with disseminated histo and other fungal infections? Is that a clue towards? We always think about TB, and certainly she's at risk for TB, but fungal infections. Every time I think about TB, I want to make sure I don't miss a fungal infection, and vice versa.
Yeah, I think if you're going to sort of lay it at the feet of one of them, it's probably more common with histo than any of the rest, or potentially even blasto. I don't feel like, certainly fevers with crypto, I don't feel like I hear about rigors and night sweats as often with things like crypto, or even aspergillus and other molds.
And is there anything you can get out of the fact that a week before she had the fevers, she had headache and body aches? And
I don't think so. I mean, there's such non-specific complaints. Okay. She's at risk for, disseminated illnesses of all sorts, and so do we need to worry about meningitis? Certainly. We want to think of it early and often, but it could easily just be a symptom of being bacteremic.
I would examine her. Oh, Gabriella. Go ahead.
No, the only thing that I would say is that TB would be lower my differential for her, because if she had a transplant a year ago, she definitely got tested for latent TB. So her developing primary TB within this 1 year, after 1 year of getting tested, is really low if she hasn't been exposed. So that's why it would be lower in my differential.
Yeah, I think that's a great point. And I think routinely they do test, but I don't know that it's necessarily absolute. And so I think it's one of those trust but verify. You would want to believe that, but you're absolutely going to go back and look at her pre-transplant serologies and see, was it PPD or a quantiferon or a T-spot done, and be sure.
I actually don't have that information.
Physical exam might really help, or
I
might
think
not.
So. So she's alert and oriented, not really in any acute distress when we first see her. AG&T exam is pretty unremarkable. She does have decreased breath sounds bilaterally with decreased air movement, as well as faint crackles diffusely, not just at the bases. For her cardiovascular exam, she doesn't have a murmur with regular rate and regular rhythm. She does have trace edema on her lower extremities as well. And then for her skin exam, she has her skin overall is warm, dry, and pink with the exception of her arms and legs. She is Caucasian, and you can see these faint brown papules. They essentially look like the color of almost like raised freckles, if that makes sense. That's kind of the pattern they're in. But they're in both of her arms and legs. They spare her hands and face as well.
What's the size? Are these pinpoint papules or are these larger?
Like 1 centimeter by like 1.5 centimeters. They're not quite circular. They're a little bit more oval. I wish I had a picture. Does that bring anything to mind?
No, I think if, again, kind of going back to the fungi, I think any of histo, blasto, crypto will give you skin findings. I don't know that what's being described is necessarily what I would pin to any 3 of those as the typical. Cryptococcus is a little bit, I would say, a little bit more predictable in what it's going to do, and what it's going to do depends on the host. And so when people were originally seeing a lot of it during the HIV and AIDS epidemics prior to effective treatment, it was very much these kind of raised, fleshy, umbilicated papules that you think of with like molluscum. We don't as often see that in the transplant population like her. Here we more typically, when people have skin involvement with cryptococcosis, see more like a cellulitis. And that can range from what looks like your typical group A strep cellulitis to a necrotizing infection to deeper paniculitis. Histo, again, it can usually be more of like ulcerations, can involve like the oral mucous membranes. It can cause that same kind of raised, fleshy, umbilicated lesions that crypto can in AIDS patients. I don't necessarily think of it with this kind of what sounds like maybe hyperpigmented papules. And blasto, again, I think is typically more deeper, more nodular, more abscess-like. I would say this probably makes things like molds and nocardia a lot less likely, because those tend to be a lot fewer, not as widespread, and more like nodules and abscesses and kind of discrete lesions.
Okay. I will give you guys some more labs. I apologize, Dr. Centaur. I don't have an ABG for you. I should have thought ahead, but I don't.
It's okay.
So her albumin was low at 2.5, mag and phos were normal, calcium was just barely low when corrected for her albumin. Her urine Legionella antigen came back pretty early in her course, it was negative. Her nasopharynx culture was also negative, and her blood cultures were negative at 24 hours.
That albumin is intriguing, but she's been sick for, she's been very sick for a week and sick for 2 weeks. And your albumin could go down pretty fast when you're sick. It'd be nice to know what it was before, and to know whether it's in her urine, to know what her INR is there something wrong with her liver? But I'm not going to get too excited about it. I'm not going to get too excited about the calcium just yet.
So I don't have her hepatic panel on here for space, but it was all within normal limits. Her INR was around 1.
I don't know, Todd, you see a lot of people who come in sick with infections. I assume that many of them have a decreased albumin because your albumin goes down really fast.
Yeah, I don't, that doesn't help me in any way.
Right.
Sort of confirms everything else she's sick.
Yeah.
Give you
chest
some
CT.
imaging. Yeah, we'll skip the X-ray again for space. So she had multifocal consolidation with diffuse ground glass densities. Bilaterally, she also had interlobular septal thickening. They said findings were non-specific and can be seen in multiple different pathologies.
Doesn't help narrow things down. Crypto can look like this, histo can look like this, maybe blasto is less likely, pneumocystis can look like this, molds remain pretty unlikely.
So what would you order next in terms of labs, just for our listeners?
I think the first thing that I would order is a cryptoantigen, in part because it's easy and fast. And its sensitivity and specificity in this instance is incredible. If that's negative, then I'm thinking about more invasive testing. If it's positive, then it can explain everything.
It's negative.
All right, so next up, given her burden of disease, you can trust that result. It's not going to be a false negative. Then thinking more about histo and pneumocystis, you can get beta-D-glucan. So a lot of fungal markers have excellent negative predictive value. Their sensitivity can be good to great, but the pretest probability is always low. So it's negative, it's hugely helpful. A beta-D-glucan lacks a lot of specificity for any particular fungal infection, but its sensitivity for any fungal infection is very, very good. A histoantigen in this case would be very positive if it was present, or if this is histo. A galactomannan, she's at risk. I don't generally like sending galactomannans in solid organ transplant patients. Their sensitivity is not as good, the specificity is not as good, and it has a lot of potential false positive issues. It's really one that I favor, at least from the serum, only sending in chronically neutropenic patients. In her, I think, she's sick enough. I don't know that Palm would necessarily want to bronch her, and we have a histoantigen and I think beta-D-glucan also now are in-house tests with a pretty quick turnaround time that I could potentially try to delay getting any sort of invasive procedure for more diagnostics.
So Todd, since this is unRemarkable Labs, you just threw a lot at us. And so for the people listening who don't use this every day, let's go over these fungal tests one at a time, slowly, so that I can remember what the hell's going on, and our listeners and people viewing.
You can do a brief overview, but our next episode is going to be just about the fungal lab. So
okay.
So I would start. I'll start with the most sort of broad, and then the more kind of specific. So beta-D-glucan, think of it as essentially a pan-fungal marker. It's a component of the fungal cell wall in most fungal pathogens. And so if it's positive, it is helpful if you're worried about a fungal infection. It does have some important things that can cause false positives. So cellulose membranes in dialysis machines can cause a false positive. Blood products can give you a false positive. And so you have to be a little bit mindful of sending it and placing too much weight into it. From there, the other tests are more specific. Galactomannan is typically specific to Aspergillus and other molds, although it can still be positive in histo as well. Whereas the histoantigen is very good. You wouldn't expect it to be positive in other fungal infections outside of blasto. You see a lot of cross-reactivity between those two. Cryptococcus antigen is almost perfectly specific to Cryptococcus, but there is one, so trichosporin is an unusual yeast that we can see that can give a false positive crypto.
Great. That helped me a lot.
Okay. So with that, I will give you an LDH was 600. Serum crypto we already talked about was negative, and her aspergillosis galactomannan was greater than 30.
That's high. I think, again, we talk about galactomannan as something we favor for aspergillus, but given her clinical condition, this sounds like histo. The way that it appears on her chest CT would fit more with histo. We can absolutely see it be cross-reactive. Either way, given the severity of illness, you're going to give her amphotericin while you try to sort out the difference.
And the last piece I'll give you is her urine histoantigen was greater than 37, which is the upper limit of normal. So you called it.
He's really good.
Yeah, this is why I wanted to start off with the labs. I knew that he's a fungal expert. I do want to ask you, what about the CT scan made you think histo over crypto or aspergillosis that you were just now saying?
So I don't think you could look at the CT and say I don't think you can distinguish between histo and crypto. Both of them cause this type of appearance. So I would say crypto, histo, pneumocystis could all give you that potential appearance. With molds, you don't usually see this diffuse ground glass type of an issue. Molds tend to be more, outside of a few kind of rare circumstances, tend to be more nodules, maybe with surrounding ground glass, and think of the halo sign that gets talked about with aspergillus versus the reverse halo, where you have a rim of consolidation in your nodule with an interior of ground glass. And that one tends to be more associated with mucor, but either can do either one.
Channeling Pappas, isn't Wetumpka fairly close to Montgomery?
It is.
Yeah.
I'm, in spite of being a lifelong Alabama resident, my general Alabama geography is not great. I am no Peter Pappas and far from a James fan either.
Well, thank you all so much.
That'd be an interesting contest between James Spann and Pete Pappas. Well, great. Thanks so much, Todd. That was wonderful. Gabriella, since you are our special guest today, what in this discussion are you going to take away and use and teach?
Yeah, I think they're really good learning points, but maybe one of the most important ones is that sending these tests in solid organ transplant patients is not as reliable. And I think we do it all the time without realizing this.
Natasha?
Let's say there was one other important lab with the LDH got put up there. And as much as we teach a lot about pneumocystis and an elevated LDH, that's a bit higher than you would typically see with pneumocystis. And a lot of times with disseminated histoplasma, you can actually see it well up over 1,000.
Great. Natasha, do you have any final comments?
No, just that this was, I think, a great learning case. I didn't know about the association with LDH and histo either until I saw this patient, because her urine histoantigen didn't come back for a while. And so with the LDH, we had a high enough suspicion for histo that we went ahead and started her on treatment for that. But we were worried that there may be some PJP co-infection. And so we treated her with therapeutic backroom dosing just until that came back negative. She did end up getting bronch. Just to tell you a little bit about her course, she did end up getting intubated and bronched. And then these studies all came back after. They weren't necessarily thinking fungal infection. And I think ID was called on maybe the second or third day of admission. She got intubated the day we saw her, and then she ended up getting treatment, getting extubated, getting sent to the floor, and then getting discharged all within a week. So she had a really great turnaround.
If you catch it early, you can absolutely turn these people around very quickly with amphotericin.
Great.
Awesome.